That is so key. The fact that now, instead of being incented to do more, there is this move going forward to do better. And I think that's really key, and that's really what's behind value-based purchasing.
But I do want to emphasize, and it seems like I'm going to take the voice of the policy wonk researcher kind of, but I also want to be, while I am in theory very supportive of the idea of value-based purchasing, at least in its classic sense, we don't have much evidence that it works. So I'm always struck by our society is devoting so much energy to this idea. The president discusses this in the State of the Union address as this is something that we need to move. Yet we don't have good evidence that it works or which type of value-based purchasing design. So we're just sort of moving forward as a healthcare system. But I have to say, personally, I'm nervous because we're going to devote a lot of energy and time to this, and we may or may not work. And I'd rather we have some better evidence that it does work, or at least maybe instead of just describing value-based purchasing as this broad idea, what types of value-based purchasing works and which doesn't, so we can devote our energy to the right things, the most effective methods.
Yeah, well, I mean, as I told you earlier, Ateev, there's a lot of evidence. It's not necessarily published, and there are a lot of reasons for that. So one, the cycle of improvement and change on the design of many of these programs has to continue to go at a pace that far exceeds the pace of studying, publishing, control groups, and all the rigor. I think the sad part, and something we're going to work on a lot more this year, is the lack of case studies and the lack of good case studies that we can collectively. I know you've done a fair amount, Dennis, but there's just not enough out there. We've been working with health plans that have massively deployed value-based payment programs. They're doing quite well, and we know that because we're monitoring the improvement over time in quality and in cost of care. They're not going to publish it. They're not going to do a case study. They look at that as it's a proprietary advantage that we now have in the field. We understand what it takes to make these programs work, and we're going to leave our competition in the dust. And in the next 2 years, when we publish our rates on the local state exchange, we'll beat the crap out of all of our competition because we figured out how these things need to work. So, you know, you look back at how the pace of change occurred in different industries, some far bigger than healthcare. And, you know, the corporate CEOs who made the decisions on how to allocate funds, where to put it, what to change, they didn't wait for published studies to do it. After the fact, you have a case study in the Harvard Business Review, but, you know, you move because you see the change occurring at a level that makes sense to you as a decision maker, and you're not going to wait for publishing. I mean, it's a whole other debate about, you know, the problem that we have in this country with probably too much emphasis from healthcare services researchers on the desire to have the perfect study, when we should throw that out and really focus a lot more on rapid learning around these case studies.
So, Ateev, we better not tell our colleagues that no one's going to wait for our studies. Before we move on to the next topic,
Thank God we're not waiting for you to study.
That's right. I want to ask one other question. Sometimes, you know, value-based purchasing inherently is trying to link payment to some measurement, right? Some assessment of value, quality measures, be they clinical measures, be they patient experience, patient satisfaction measures. But the measurement industry is often used as a sort of reason for why we shouldn't move forward. Measures aren't good enough. They're not robust enough. They're not properly severity adjusted. Anybody want to comment on that? Is there any validity to that excuse, that the measurement really hasn't kept up with where we're trying to go for value purchasing?
I'll take the first crack at it. First of all, there is lots of validity around it. I just finished a report for the state of Tennessee because they're looking to pair quality measures with bundles. And we could find quality measures for about 2/3 of the bundles. So that leaves a third without any measures. For the 2/3 for which we could find measures, I'd say that probably only half, so a third, had very distinct measures that gave you a certain line of sight on actual outcomes of care. The balance had associated measures, but nothing that was really very specific, and particularly in surgery, by the way. And so I don't think that's going to change anytime soon, Dennis. And I've been now increasingly telling medical specialty societies, the world has changed. We are moving to this value-based payment. You're going to probably bitch and moan that where there's too much emphasis on cost or price and not enough emphasis on quality. But it's your own damn fault, because for the past 2 decades, you've co-opted the measure measurement system to make sure that the only measures that see the light of day are measures that cannot distinguish your performance. So if everyone scores a 90 plus on a quality measure, guess what you're going to be judged by? Right, so it's your own fault, and at this point you need to wake up and find measures and develop measures and submit measures for endorsement that actually show differences in quality, not everyone at the 90th percentile, because we know that that's not true.
So we're
I
going to
would
come back.
I would also pose that it's not always easy to measure quality. It's not always quantifiable. Sometimes it is, but not always. In medicine, we're always looking for numbers. For example, you can evaluate a physician based on how often they hold down a hemoglobin A1C level, or you can look at someone's cholesterol level or blood pressure. But there's so much in medicine and the delivery of healthcare that's not measurable with a number like that. I'm convinced that a lot of what we're doing and the way we're going forward will improve the delivery of care, but I'm not sure we can expect an exact number on everything we're trying to measure.
Got it. Well, we'll come back to that measure.